Hello there. This is an answer and discussion clip on the video that we posted yesterday on YouTube and on Snapchat. The abnormality is obvious. You have multifocal bilateral lung opacities. Now, airspace opacities could be classified into consolidations versus ground glass. They're both increased lung density. If you have an increased lung density that obscures the underlying lung markings, that's called consolidation. If you have an increased lung density that does not obscure the underlying lung marking, that's what we call ground glass opacity. In this case, you have increased lung density that does not obscure the underlying lung marking, and that's why these are ground glass opacities. The other thing that some of you have noticed is that you have interlobular septal thickening in the abnormal areas. And the combination of septal thickening and ground glass is known as crazy paving. Now, it's important to notice that the areas of septal thickening do not show any architectural distortion. There's no traction bronchiectasis. There's no volume loss. And the septal thickening itself is not irregular. So this means that these are not reticulations, meaning that they are not fibrotic in nature. Now, it's very important in such cases to decide on the distribution of the findings. Even on an axial image, you could tell that the abnormality is less pronounced in the upper lung, more predominant in the lower lung. So number one, this is a lower lung predominant abnormality. Number two, you have to decide if the abnormality is central, peripheral, or diffuse. In this case, you have multifocal, subpleural, or peripheral opacities, such as what we see in these locations. In addition, you have the central perihilar abnormalities that surround the airways and vessels in what we call a peribronchovascular distribution. So to summarize your findings, you have a multifocal, bilateral, subpleural, and peribronchovascular abnormality that's mainly constituted of ground glass opacities with areas of crazy paving, and that have a lower lung predominance. The coronal image shows the same abnormality and is better suited to show you that it's more pronounced in the lower lungs. The sagittal reformat is also nice to show you the lower lung distribution. For the sake of completion, the soft tissue window that we showed yesterday did not demonstrate obvious abnormalities. In particular, you don't see dilatation of the pulmonary artery. There is no lymphadenopathy in the hyla or in the mediastinum, and there are no pleural effusions. So back to the lung window. Now, this is a good chance to revise the differential diagnosis for subpleural or peripheral airspace opacities. This includes organizing pneumonia, eosinophilic pneumonia, septic emboli, pulmonary infarction, vasculitis, and contusions. We will not discuss each entity in this clip for the sake of time. It would be a good chance for you to go and read about the differential diagnosis that we just mentioned. However, it's very important to know that you could easily differentiate these categories based on knowing the clinical information and on knowing whether the patient presents in an acute or chronic fashion. Whenever you describe a bilateral lower lung predominant airspace process that has peribronchovascular and subpleural involvement, you're typically talking about organizing pneumonia. Let's pause here for a while and talk about organizing pneumonia. It's just a nonspecific lung reaction to many insults. Organizing pneumonia may be idiopathic, and that's what we call cryptogenic organizing pneumonia, COP, or what was known as bronchiolitis obliterans organizing pneumonia, BOOP. And even more commonly, it could be secondary to causes such as infections, drug reactions, rejection for transplantation, and connective tissue disorders. Now it becomes easier. I'll tell you more about this patient's history. This is a patient who is known to have rheumatoid arthritis, who presented with a 3 to 4 weeks history of dry cough. He had no fever, no leukocytosis, and he was not on any medications. Now it's easier to tell that these abnormalities actually represent organizing pneumonia secondary to rheumatoid arthritis. Thanks for watching. We'd appreciate your comments on this discussion. There's much more to say about this case, which we could discuss there, and see you later. So please join in by commenting below. Give us your thought on the findings, the approach, and the differential diagnosis. And also help us by sharing, subscribing, or liking our videos. Don't forget to follow us on Twitter, Snapchat, Facebook, or Instagram.